My name's Bailey, and I'm a nursing instructor with the Annie Taylor D School of Nursing at Weber State University. And today we're going to be talking about cardiogenic shock. So cardiogenic shock is a form of shock that occurs when our heart is not functioning adequately. Rather than having a volume problem like we do with most forms of shock, our heart is just unable to adequately pump blood through our body to perfuse it adequately. So just remember that cardiogenic shock is a result of a pump problem. So what causes cardiogenic shock? Cardiogenic shock is often caused by either coronary or non-coronary issues. A coronary cause for cardiogenic shock would likely be damage to the muscles of the heart, and most commonly this is a result of a heart attack or an MI. Non-coronary causes of cardiogenic shock are due to arrhythmias or cardiomyopathy, and while this is still possible to happen, it's much less common than coronary issues are. Now, in cardiogenic shock, we'll typically see that the patient develops hypotension and tachycardia, meaning that they have low blood pressure and a high heart rate. Generally, we characterize hypotension as a mean arterial pressure, or MAP, less than 65 millimeters of mercury. And the reason that we're hypotensive in cardiogenic shock is because, again, the heart is unable to adequately pump blood out of the body, leading to a reduction in cardiac output and therefore a reduction in blood pressure. Remember that cardiac output is the volume of blood pumped out of the left ventricle every minute. So in cardiogenic shock, we'll see that the volume is less than 4 liters per minute because our heart isn't squeezing that blood out effectively. Our heart rate's going to try to compensate by increasing. So generally in cardiogenic shock, we will also have a heart rate greater than 100 beats per minute. Because our heart is unable to adequately pump blood out of the body, blood will instead start to back up. And for this reason, we typically will see increased pulmonary artery pressures in cardiogenic shock. Think that if the blood isn't moving forward, it starts to move backwards, leading to high PA pressures and pulmonary congestion. So a normal pulmonary artery pressure is about 20 to 30 over 8 to 15 millimeters of mercury, but in cardiogenic shock, these values are going to be higher because there's more pressure in the pulmonary artery due to that backup of blood. Lastly, we'll see an increased systemic vascular resistance in cardiogenic shock, or an increased SVR. And this is because our body tries to compensate for the decreased cardiac output by vasoconstricting our vessels and making them tighter. And so this makes it so that our heart is trying to pump against higher resistance because we are pushing blood through a tighter vessel. And this will also increase the workload of the heart. So how do we treat cardiogenic shock? First, we must identify the cause of the cardiogenic shock. If we have a patient who's experiencing an MI or a heart attack, we need to reperfuse the coronaries by doing some type of percutaneous coronary intervention, or PCI. If we have a patient who's having arrhythmias, then we need to try to get them out of that arrhythmia by giving them medication or sometimes doing a procedure like a synchronized cardioversion. Second, instead of giving lots of fluid like we would in other types of shock, in cardiogenic shock, we typically need to help support the heart by using inotropic medications, which help improve the squeeze of the heart. So for example, we can use epinephrine, dobutamine, dopamine. These are inotropic agents that will improve that pumping action of the heart and improve our cardiac output. And last, or third, we can give medications like diuretics or nitroglycerin to decrease the workload of the heart and help it to function better. And they do this by reducing preload, or the volume that's in the heart. If we have a heart that's already not pumping effectively, but it's now overloaded with volume, it is going to function even less adequately. And so by reducing preload, we're able to help our heart pump more effectively, therefore increasing cardiac output and improving hypotension.